Good evening. Thank you once more for joining us today. Welcome to this learning session hosted by the Health Leadership Academy. My name is Liz, and I'm delighted to be your host this evening. A little insight about the Healthcare Leadership Academy for those joining us for the first time. We are a social enterprise that delivers programs to equip healthcare professionals in the core areas of leadership, quality improvement, and management. You can please visit our website at www.hlaafrica.org for more information about us. Today, we are excited to look in the direction of utilizing quality improvement for healthcare professionals and leaders and how this can improve patient care outcomes. We are joined by a very special guest and a dear member of the HLA family, Dr. Kendra. We thank you for joining us this evening. Before we get started, I would like to just remind us that because this is a learning session, it's also an opportunity to get answers to your questions. So I encourage you, all the burning questions that you have, please locate the chat box and drop your questions. We'll take them in the order in which we receive them. I would like to just take a short period to just introduce our speaker to us. Dr. Kendra Njoku is a medical doctor and public health professional with over 15 years of wide and varied experience in global health, both at the local and international frontiers. She has driven innovations resulting in health system strengthening, supporting multiple governments, organizations, and health facilities. Her expertise and experience spread across quality management, patient safety, digital health solutions, data management, capacity building, self-care management, and disease management. She serves as the Faculty and Improvement Advisor at Institute for Healthcare Improvement, IHI, which is a leading global health organization focused on quality improvement in healthcare. In this role, she supports several countries and organizations across the Africa and Middle East/Asia regions in using quality improvement methodologies to achieve the SDG goals. Through her support and capacity building, the impact of large-scale learning collaboratives and initiatives have resulted in reduction in premature mortality, maternal and neonatal mortality, transmission of HIV from mother to child, as well as improved clinical processes. She was the head of programs and quality lead at MDoc, a digital health organization that leverages quality improvement methodologies, behavioral science, data, and technology in the provision of self-care support to people living with regular and chronic health needs. She led MDoc's digital health solutions and quality initiatives across several countries and partnerships, including the MSD-funded Reducing Indirect Causes of Maternal Mortality and Morbidity project, as well as the Project ECHO Multiple Networks. She was at the front line leading MDoc's COVID-19 response across Africa. She is the lead facilitator and faculty for the different quality models offered by MDoc under the MDoc Quality Network, teaching practically several quality improvement methodologies, such as the Model for Improvement and Lean. Prior to joining MDoc, she held the position of quality manager at Farm Access Foundation, a group of non-profit organizations dedicated to improving access to quality healthcare in Nigeria. Dr. Njoku led the institutionalizing of quality assurance and improvement mechanisms in over 100 facilities across multiple states in Nigeria through the Safe Care Certification Program. Our experience also includes our work with Doctors Without Borders, standardizing processes, and leading the quality assurance portfolio. She has an MSc PH from London School of Hygiene and Tropical Medicine. She's a fellow and member of the International Society of Quality and a certified improvement advisor. She graduated from the University of Port Harcourt, Rivers State, with a Bachelor of Science in Medicine and Surgery. And just to round up that beautiful, very expansive introduction is also the fact that Dr. Kendra also serves and supports the HLA as faculty member. Dr. Kendra, welcome and good evening. We're excited to have you join us today.
Thank you so much, and thank you for the warm introduction and reading of my background. I'm really excited to be here today. I'm really excited to see so many members that have passed through the HLA Academy still being connected to the quality improvement space. So looking forward to a lot of productive discussion this evening.
Awesome, thank you. So let's get right to it. I know we've read your profile and just given like background of your work and your career, but Could you kindly share a bit more about yourself, how your career journey has evolved, and what were the influences that contributed to you working in this space? Just a brief.
Okay, so as many people who know me, I'm simply called Kendra. I am mom to two beautiful girls. My first daughter just turned 13, a milestone last week. So we're still in cloud 9 about being the mom to a teenager. In terms of work, I think right from growing up, I've always been a talker, for those who know me, and I wanted to do law. My first love was actually to do law. I was good at making my points and talking, but I was also good in sciences. And you know what the parents were doing then. Your intelligent child definitely has to be a doctor. So for me, public health was a way of marrying my two loves. Being able to still speak, as well as be in the healthcare space. And so right from school, while many of my mentors in school, lecturers, felt it was a waste to not do clinical medicine per se, to enter public health, it's always been my passion. And I think that has been my joy and fulfillment in the work that I do.
That's interesting. I like how you've been able to, not many people, are aware enough or able to access the resources that they need to marry, where life has sort of orchestrated them to be and what they truly enjoy doing. So that's a blessing, and I'm excited that the world gets to benefit of your journey and your experience so far. Okay, the first question I would like to ask it, because today is an Ask the Expert session, so I would like to just get right to it. Today we're talking about quality improvement. What are the elementary building blocks of quality improvement that every healthcare leader or organization ought to know? As requested, I'm going to please share my screen.
Okay, that's a great first question. What are the building blocks of quality improvement? And, it covers really 3 areas. And, your ability, and for everyone on call, the screen is going to come. Yes, thank you so much for sharing this. So there are 3 main buckets. How do you look at person and family-centered care? How do you look at your infrastructure, the culture and the infrastructure? Those are a very key bucket. And then how do you learn from your system? What mechanisms have you built into your system that makes the way you run your business, the way you run your health facility, a learning environment? And these building blocks were put together by Dr. Peter Chamberlain. So let's start from a very key component, which is person and family-centered care. If you want to get on the quality improvement journey, which is a journey that you can never say you've arrived at your destination, is an always evolving journey. You have to have a patient and family-centered model of care, where you see an individual, not just as the patient, not just as an individual, but looking at the family as a unit of care. So for example, you're treating a diabetic man, a man with diabetes, right? How do you not just see him as his blood sugar level, but understanding that what he eats is influenced by what his wife prepares, his wife's understanding of what he should eat and not eat. So how are you treating that individual, bringing in his family so that you can offer personalized care, what works for him? How are we moving from asking the person when they come to us, we're trying to find out what matters, what's the matter, right? Moving from that fully clinical mode of what's the matter to asking the patient, what matters to you? Okay, so we're dealing with diabetes, okay? As we talk about your nutrition, what is important to you? How can we work together to make sure that we don't take out everything that is of essence to you? so that your compliance can even be increased? How are we co-designing with the patient and family, hearing the voice of the patient as we go about our quality improvement, so that we are not acting as know-it-all doctors and nurses and healthcare professionals, but we're hearing the voice of the patient. We're moving from, it's like, I always use this example when I teach, it's like parents and uncles and aunties coming together to decide this child will read medicine, without bringing the child into that meeting to say, what do you want to study in school? So it moves, it can be about the patient without the patient. So one key element is making sure that you have a patient and family-centered care model. The next thing is, there has to be structure. What infrastructure have you put in place? What culture are you building to ensure that quality improvement can strive? Do your workforce feel valued? Do they feel motivated? What's the morale in the room? Do they have the psychological safety to report up or report sideways or even report downwards when they have erred, when there's a mistake? Or are they afraid of capital punishments? Have you built the culture where people can own up and say, I had a near miss, I had a mistake, and then you make it not about the person, but about understanding what went wrong and how we can prevent it from happening again? Do we have leadership that is at the front lines, that does the Gemba work, that moves out of the office? Or do we have leadership that is so far away from the reality? So you're in your office designing, blaming, producing quality improvement initiatives without understanding your system, without appreciating your system. Does your workforce as a leader understand what exactly is your focus, your relentless focus, your goal? Is that clear? Are the people within the system, your health system, your health facility, your state ministry, are they working as a team, or are they working in silos? How are we using data, linking clinical practice with data to inform decision-making? What's the capacity of your staff? So you want your staff to do quality improvement. Have you trained them? Have you capacitated them? Have you empowered them to really run quality improvement initiatives? Do they feel they have the empowerment to be innovative? The last big block, and really, really important, is, do you have a learning system? Do you have a system that allows you capture your issues, your complaints, your feedback? Is there a functional system? Many of us have this very dusty suggestion box, long forgotten. Nobody even knows where the key is, right? But do you have vibrant systems that you can get real-time and periodic feedback from those you serve, from those who work in your system? Do you have mechanisms where each segment, each part of your system is looking continuously at improvement, identifying gaps, getting the root cause analysis of those gaps, and closing those gaps with quality improvement methodologies such as Model for Improvement or the Lean system? Are you in real time? For you to learn, you need to measure and see what your current performance is compared with your past performance. So do you have systems and measures in place that help you track your improvement journey? These are really essential building blocks for quality improvement.
Awesome.
Elizabeth,
Thank you, Dr. Kendra. Thank you so much. Sorry, I was trying to unmute myself. Thank you. So I understand that quality improvement is quite the broad scope, has quite a broad scope. But just to narrow it down a little, how does the understanding, because you've done a really wonderful job of giving us the building blocks, like the foundation, how does this understanding and application of this QI evolve when we now view it from a patient-centered care perspective? Like if we focus primarily on the person and family-centered care building block, how does that?
So, don't harm me.
Okay.
Heal me. Be nice to me. In that order is one of the tenets of great healthcare in the patient perspective from surveys done. I'll repeat it. Don't harm me. Heal me. Be nice to me. In that order. And so don't harm me is, I am coming to you with this ailment. Please don't add more wahala to me. Don't misdiagnose. Don't mistreat. Don't give me expired drugs. Don't harm me. Give me safe treatment, right? While you're not harming me, the one I've come to you, the problem I've come to you with, can you treat me right? Can you heal me by giving me the right treatment, right? And while you're healing me, can you do it in a nice way? Can you understand me as an individual, as a person requiring respect and dignity, right? What does patient-centered care mean? It simply means taking into cognizance, being mindful, respectful, and accepting of a patient's experience, their preferences, their beliefs, and including them in the decision-making in their health, for their patient care, right? And so, if you were to, how do you incorporate the voice of the patient into your initiatives? So for example, if you want to improve patient satisfaction of your inpatient care, in terms of a patient perspective, right? You might sit down in your quality improvement meeting and be saying, oh, the patient wants this kind of bed, and if we give this kind of food, but that might not be what matters to the patient. So it's getting the voice of the patient. For that woman on your admission ward, it might be a change to your visitation hours. Your visitation hours probably 4 o'clock to 7 o'clock. Her daughter, if you live in Lagos, her daughter works in Victoria Island. She's admitted in Ikorodu. Before she can get to from Victoria Island to Ikorodu to visit the mother, you say your visiting hours are over. What does it mean in terms of, okay, she's here? How in a sense of giving information to the patient, not just tell that patient that, tell that patient that your results are fine. Many times when I interact with patients who have been to the hospital, I say, what's your BP? Oh, they say it's normal. They say it's high. They say it's fine. Like, it is condescending to just outrightly believe that if I break this down in a meaningful way to this patient and the family, they would not get it. They're too dumb to get it. There's a way we can pass health information, to break down health information and pass it to the patient and relations in a way that serves purpose, that makes them understand. So what does it mean? It might simply mean taking the time to talk to that man's relations, do a Zoom call with his children who are not physically present, but really want to know what is wrong with Baba. How are you intentionally incorporating the voice of your patients into your quality improvement initiatives? Is really understanding and practicing patient-centered care.
Thank you, Dr. Kendra. So what I'm thinking, the next line of question that comes to mind really is, if we're looking at patient-centered care, and want to talk more about it extensively, especially in light of what our current health system looks like. Just before I joined this call started, I was listening to a podcast, and these doctors were talking about some of the experiences, with caring for their patients, just the way that the system is ailing and sort of failing, and how things are not working, the lack of proper infrastructure, sometimes even just health insurance, sometimes they having to crowdfund to pay for their patients' needs. So when we talk about patient-centered care and being more open, or being more intentional about carrying patients along in making the decisions, or just keeping them informed, what are the understanding these realities that we face currently, especially in Nigeria, how can our healthcare leaders or organizations sort of design health systems, I don't know, or work to improve the current health systems that we have so that they are patient-centered, having this understanding of the importance of patient-centered care?
I think one of is the intentionality to be patient-centered, having it as one of your top goals. And we say, if you don't measure it, you can't improve it. So how many of our health systems have patient-centered health outcome measures that they're tracking, right? You can't improve it if you can't measure it. So I think one of the first steps is getting your patients involved. Do we have patient advisory members in our quality improvement meetings, where you can get the voice of the patients? How do we get feedback from patients? What do we do with that feedback? Are we looking at it, doing root cause analysis, understanding what our patients want? That intentionality, we're going through this process, but not just stopping there. Many of us stop halfway. We find out what the preferences are, and that's where it stops. We don't test it out, in the PDSA cycle. We're not tracking periodically. Are we really keeping this measure? And what are some of these measures? Your patient satisfaction scores. How are you tracking? A woman comes to give birth in your facility. How are you tracking her birth experience? Right? Her experience with the care that you've given, her experience with your pain management, her experience with your supportive care. Did you just tell her, like you told her in ANC, you have to breastfeed your baby between 1 hour? Or did somebody actually come and lift up that baby for this tired postpartum mom, position the mom right, and help her latch the baby on? So there are different surveys that we can find online linked to measures that can actually help us track. Do we have a plan for patient-centered care? Are we testing out that plan? Are we measuring results from that plan to see that there's an improvement in our patient-centered care outcomes? That is definitely one way to go about moving from talking the talk to doing the work.
Excellent. I like the way you ended it, talking the talk to actually doing the work. Thank you very much. I'd just like to remind us that we can please drop our questions in the chat box, and we'll take them in the order in which we receive them. Dr. Kendra, I'm just wondering, how does quality improvement, looking at it from like an overview, how does quality improvement benefit both the caregivers and the patients?
Okay, I would link this to the international, the Institute of Medicine dimensions of quality, right? When you practice quality improvement, you're looking to improve the quality of care to better health outcomes, right? So the first thing is you improve safety. You do not harm the patient. You improve that you're giving safe care to the patient, which is aligned with the first thing that matters to the patient. Do not harm me, right? When you give improved quality of care through your quality improvement initiatives, you're giving effective care. Effective care is care that works. You are healing the patient. the second tenet, right? You are also, when you say patient-centered care, because you're practicing quality improvement, right? You would be practicing patient-centered care, and which leads to patient satisfaction, which leads to the way you, not only the way you treat patients, but the way you engage patients, which in turn, one benefit, because yes, we want revenue in our facilities as well. It increases your footfall. If patient satisfaction increases, your footfall to the hospital increases. Those people return to the hospital. Those people become your networks to referrals. They refer people back to the hospital. Your revenue increases. It also makes you efficient. It removes waste from your system. Quality improvement, efficiency in your timeliness, efficiency in your purchases. You know, you're looking at, expired drugs is no longer a thing, because you have your reorder levels, your minimum levels, your maximum levels. Somebody is tracking it. You're using data for informed decision making, so you know what amount of each drugs to buy based on the common ailments that walk through your doors. It makes you proactive, that I'm not waiting for the shoe to drop. I'm actively preventing mishaps from happening, and that improves your health outcome. These are just some of the benefits, and definitely cost effective, which everybody likes to hear.
Of course. Thank you.
Cost effective in the long run.
In the long run. Noted. Thank you. How can a facility, and this sort of just is the perfect segue for my next question, how can a facility improve the quality of its healthcare services without increasing its overhead costs?
Okay. So we always say, within the resources that you have, what can you do better? Right? We don't run, unfortunately, we're not in a perfect system. So most times when you tell health facilities to do a fishbone analysis, or, you would see lots of, or a 5 whys, you would see lots of facilities saying inadequate staff, inadequate equipment. They go straight to the infrastructure, and believe me, infrastructure has a huge role to play that I'll come to in a minute. But in quality improvement, what can I do? A key question is, what can I do differently on Monday within the resources that I have? Yes, what I can do now might not make me hit the 100% targets, but it can get me 27% towards my 100% targets. Why will advocate for more resources, more of everything we have? What can we do within the resources that we have now? But again, understanding that the Donobena's model will say structure plus process equals outcome. So you must have those structures. You must have the staff. You must have the equipment. You must have the protocols. You must have the structure in place, and the processes are now, how are you using those structure to yield your outcomes? So no matter how we say, work with the resources you have now, quality improvement does honestly require some investment. So for example, if my quality improvement project in my health facility was to increase the triaging, right? Appropriate triaging of patients in the OPD. And I do not have a suite. I do not have a standiometer. I do not have, all the necessary devices that will help me triage. No matter how much I huff and puff, nothing is going to happen. Those are fundamental things that must be there for me to improve triage. I need the speed to check BP. I need the thermometer. I need the scale. I need those things. So there's no beating around the bush. But what we're saying is that what we're saying, the essential infrastructure that might need some capital to put in place. But quality improvement does not wait for a perfect scenario. Start where you can. Get the necessary fundamental things you need in infrastructure-wise, but never let the lack of a perfect situation be the reason why you do not do your quality improvement. I hope that makes sense.
That's tweetable. Never let the lack of, infrastructure, prevent you from taking steps towards quality improvement. Thank you, Dr. Kendra. And this sort of just leads me to what I'm thinking next about challenges and limitations. What are the peculiar threats or limitations that healthcare organizations or facilities, face in innovation? Because something else that a key element of quality improvement is innovation, right? So innovating in delivery of care, looking at it now from not just from Nigeria, but Africa as a whole, what are the peculiar threats or limitations the health organizations will face and should look out for?
Okay, so this is a very interesting question and a very pertinent one. And I know that everybody in the health system is feeling this threat. So I would actually like to open this up to the audience to either unmute and share or chat it into the group, what they think are some of the barriers or threats that they're facing to innovation in quality of care.
Wonderful.
Any thoughts?
Okay. You can please unmute your mics or raise your hands, and I could just call if you have some opinion to share. Thank you.
And while we wait for that, when we say healthcare innovation, it cuts across, it could come in different forms. It could come in new forms of health professional training. It could come in service delivery models, in health financing models, in ways we do patient education. It could even come in drug therapies, so it cuts across a lot of things, but innovation is really just not doing the same thing over and over again, expecting different results. Yes, so I see a hand up.
Michael Olabanji,
yeah.
Thank you. You can please share with us. You can unmute your mic and share. Okay. While we're waiting for Michael, Kaine Data Speak says behavioral factors, resistance to change.
Yes, that's a very key one. You need people to change. And we normally say that there could be 3 reasons why they're resistant to change. People might be resistant to change because they don't know, they're unaware of what you're trying to do. So you tell them, you inform them. People might be resistant to change because they are aware, but they do not know how to do the change or the innovation you're bringing about. Fear of innovation, those ones you train. And at the top of the pyramid, they're just those laggards and those, difficult people that they know about the change. They know how to do it, but they are just stuck in their old ways. Those people are the people, you pray for them to leave your facility if you don't have the power to fire them. But really, resistance to change is a major barrier.
Okay, thank you. Michael shared something. He says the major one is organizational culture, and I think that you've talked about it, touched on it earlier.
Mm-hmm. Yes. We have a lot of, it's not my father's business, it's not my father's property, please, I will not kill myself. Or even the culture of, if you speak up, you're blamed, so no psychological safety. Have you created the enabling environment for people to practice quality improvements and be innovative?
Okay. Aziz Hamzat, I'll come to your question. Thank you for sending your question. Dr. Kendra,
so
I think those are the responses so far.
I can give some. So I think generally high stress environment is a barrier to change. And this high stress environment is within the health facility, outside the health facility, is everywhere on every aspect of the land called Nigeria, or, we have we're short staffed. The staff who are there are burnt out, low morale among the staff. I mean, a burnt out staff is not going to be creative, to be innovative. They just want to get to the end of the day, get to the end of the shift.
That's
and
true.
all this leads to the staff immigration. Canada, US, UK, Australia, anywhere but Nigeria, we're having the mass exodus of healthcare workers. So that's going to put a strain on the system. We really just, I mean, for me, in some ways, we don't have the enabling environment. We don't have appropriate budgets for health, much less budgets for innovations on the health. The people that we serve, there is a low health literacy among the people that we serve, right, fundamentally. And so we need to address that for us to be able to practice some of the innovations that we see working in some of the other countries, because we need the patient buy-in and health literacy to do some of these innovations. We have, very low acceptance or poor knowledge of digital health solutions, right? A lot of innovations are happening. COVID opened our eyes to the opportunities of digital health solutions, but we're not really using that. There is also a barrier, is the industries are working in silos. There's not enough cohesion and collaboration between different industries. In fact, cohesion within the health industry and other industries. For example, there's a lot of learning to be gotten, the health industry can get from hospitality, from hotels, from aviation, from banking system, right? Around quality improvement, patient-centered care, or customer or client-centered care. There's a lot of learning to have, but we don't have enough platforms for this learning and for this peer learning and sharing to happen. This is just to mention a few of these barriers that we have. I think we have some more messages.
Yes, thank you, Dr. Kendra. Those are additional questions and just comments.
Okay.
So I'm thinking, with some of the barriers and challenges that you've mentioned, what's the way forward really? Because, for example, with what you mentioned, that's pretty critical, which is the use of digital health solutions, or just collaboration with other industries or sectors. What really is the way forward? How can each one of us here on this call, at our different levels and spaces, contribute to getting the ball rolling, as it were? What's the way forward?
I mean, there are multiple things that we can do. I think the first thing, for anything to thrive, for a plant to thrive, it needs, an enabling environment, the right soil, the right water, sunshine. It's the same thing with our health system. We need an enabling environment where we don't just talk, we do, where we look. So at the level, I mean, we can start right from the federal ministry to the state ministry to the facility management to even the consumer of health services, right? But at the level where we are, within the resources and the influence that we have, how can we create an enabling environment for our workers, right? We'll probably not be able to afford them what they would like to make, the strike, all those kind of things. But what innovative ways can we increase joy in work? That we're all in this together, but at least there is some respite that can create some joy in work to do what we need to do. How can we look at innovation across the industries? What can we learn? What can we observe from these other industries that I've mentioned that we can adopt and adapt to the health sector? How can we renew our creativity? You know, we're always saying, think outside the box. Right now, we need to go outside the box. We're past the stage of thinking outside the box. Step outside the box, see what's happening elsewhere, come back, adopt it, adapt it to your setting. So again, it's just the first step when we're talking about the Deming's profound knowledge. We say one of the first lenses, right, for the knowledge you need to create quality improvement is appreciation of your system, understanding your system. We need to look at our system, and one person's system might be different from another person's system. So if you're the head of a facility, look at your system, look at your healthcare workers, have one-on-one dialogues, have focus group discussions. What can we do better? We can't solve it. Pardon me, but it's a big mess, right? The system is a failing system. We can't solve all the things that they say is a problem for them. We can't afford to pay our nurses 1 million naira, right? If you're a private facility. But what can you do within your power to show understanding and increase joy in work? What can you do around your system to be innovative and not, wear the black hat of, oh, it won't work in our setting, we can't do it? What digital health solutions can you take in place? It may even be the way you do your appointment system. It can be the way you send text messages. There are automated text messages you can send now to remind people of appointments, or automated messages you can send to your pregnant women to give them a health education tip. Think outside the box. We always get automated messages from either our network providers or somebody trying to sell something. Can you adopt that as an innovation and apply it to something, to a gap in your facility? Just not being more open to looking at what innovations from outside the box we can bring into our own box.
Thank you for these very practical examples of how we can, reimagine innovation and sort of customize patient-centered care solutions. Thank you, Dr. Kendra. Very helpful. I want to take Aziz's question. He's asking, what kind of relationship should exist between the QI team and the direct caregiver if we have a supervisory if what we have is supervisory between the caregiver and team? I'm not sure I get that question very correctly, but he's asking what kind of relationship should exist between the QI team and the direct caregiver.
Is it possible to unmute Aziz and ask that question?
Aziz, are you still on the call? Could you kindly please explain further your question? Seems like it's a bit
okay.
While we're waiting for
okay, go ahead. Yeah, go ahead. I wanted to attempt the question.
Okay. Hello,
Aziz. Thank
you. Yeah. With what we have in most of our facilities, we have what we call quality improvement team that goes around to assess how processes are being done in various units. So the situation we have is such a way that the team goes around, observe a gap, rather than discussing with the direct caregiver what he has observed, what can you do with what I've seen. Sees that as a lapses on the side of the unit. And they're taking up the unit as saying there's something wrong, because when you are in a system or in a particular unit, you don't see beyond the framework of your unit. It's somebody outside that will come around and observe something you cannot see. So we are like each other's mirror, but what we have is a situation where the mirror comes around and starts saying you has not been observant, have not been. So I want to know what kind of relationship should exist. Should it be a kind of an observer or a supervisory Because what we have is more of a superficial. You are not doing it well. There's a blah 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 blah. As if hell will fall. As if you are not being concerned about what goes around you. So that's my question.
Thank
you.
you.
That's a great question. First of all, there are different methods by which you can detect any gaps in the system. Observation is only one of them. So if the quality improvement team is only using observation, that might limit the identification of issues. We normally say use at least 2 methods, right? So that you can triangulate. One other method they should use is actually talking to the patients, but not in a, and also their approach is very important. If the workers in the unit are sensing that they're coming like in an inspectory role, coming in the detective role with the, microscope to pick out faults, people will act differently when they're around and might not allow, and they might now fail to observe the true nature of things. But if they come with an approach that, hey, we're coming for learning so that we know how to improve. So it's not a fault finding mission. You're finding out, first of all, what works well and what does not work well. So you know how to amplify what works well, and you know how to change what does not work well. So I would, suggest to that quality improvement team to also include bedside interviews that can be casual, a checklist, a survey, so that, talk to them, oh, how are you doing? How was your night? Find out some semi-structured questions. So you can have both a structured survey, or you can have semi-structured dialogue that you have, so that you can really sense what is happening, but also interact with the owners of the unit to understand, okay, even if this is a gap, why are we seeing this gap? So there should definitely be direct contact between the quality improvement team and the clients, in this case, the patients. Does that answer your question? Does that help?
Yes, perfect.
Thank you, Dr. Kendra. So I'm just thinking, because you mentioned, measurement as a very key key factor or key element in QI as a whole. So I'm wondering, what are some of the tools or equipment that healthcare leaders and organizations can adopt in measuring improvements in patient care and satisfaction, so that we are seeing whether the plan we are putting in place, whether it's really yielding results, or what are the gaps we need to address?
Okay, so for you to measure, you have to be bold enough to want to know the answers to the questions that you pose. Many times we just do it for doing sake. Oh, do you have, maybe you're in a certification, you're in a safe care certification process, or you're in a, you're in a quality, and you just do it to check the box. But it takes courage to be able to look at your feedback, right? And you can get this feedback in several ways. You can do the common patient surveys. This can be in person when they're within your facility. So before they get discharged, or at the end of their consultation for the day, you get their feedback in person through, a paper form or verbally. This can be offline through a text, asking for feedback, or a phone call, a phone survey. It can also be online. A lot of facilities are using Google Docs in very creative ways, depending on who the type of clients you serve, how digital literate they are. in this day of social media, it's also great to leverage social media, right? You can have different social accounts on Twitter, Instagram, Facebook, where you can put a poll. Have you used us lately? Rate us, where you can ask your clients to go and drop their feedback. There are also third-party review sites, right, that you can do. I have actively become a reviewer on Google, right? And so anywhere I go now, I drop pictures, I drop reviews, and I see, and I've checked out reviews of some hospitals, you know, and there are great things there. So that awareness is rising, especially if you're living in a metropolitan state. So even, you know, gone are the days where you say, oh, it's only private hospital clients that can be that savvy. With the economy as it is, I promise you, a lot of digital savvy people are using your public facilities.
This is
you
true.
know, and can use and can use this services as well. So, you know, how active are you in asking your clients? And it also increases your visibility and your footfall to use sites like Google, you know, to ask your clients to give Google reviews on the Google Map site. There are also websites like MDoc's Navi Health, which is a directional site that tells, you know, your facility is up there, geocoded. Someone can leave your facility and go drop a review. So how innovative are you in searching out all these things? You know, there are lots of people now, they would not go to a restaurant or go to a health facility or go to a, you know, a service without checking, a hotel without checking reviews. Before I chose my dental clinic, I went and I checked the reviews. So don't keep limiting and in a really patronizing way, underestimating your clients. Yes, there are the market women who come to your facility that might not be able to do this, but there are also a cohort of individuals that can do this. So how creative can you be in, you know, using the sites? And again, when you are designing what your review tool is, go for three things. Brevity, it should be short and easy to do. I, for one, if I'm filling a review and I see next and I see next, I'm out. I want it, you know, to be short and not take my time. So it should be short. Your question should not be ambiguous. It should be very clear, and you should be consistent and sure of the flow and what you want to ask your members. And make sure you're asking them things that matter to them too, not just things that matter to you. Things that matter to them, you know, is really important. So those are just some ideas around using the usual surveys, but also being innovative with social media and this third-party review sites that are gaining momentum.
Thank you, Dr. Kendra. Very practical answers. And I'd like to believe that everyone on the call can benefit from one or two of these tools. Thank you so much. Iseko has a question. How do you manage cost of quality improvement in a competitive environment? That is, most third-party financiers do not care about quality forcing competition, forcing competition to be almost solely based on cost, except of course, gross sentinel events. Quality seems to almost always be long-term and waiting for the market to recognize and identify quality as an important reason for choice. So how do you manage cost of quality improvements in a competitive environment?
I think that is so important when quality is perceived by some people who might not even know what quality is, or forced or not care about quality as long as no drastic adverse events happens, right? I think on just understanding that economy has a place to play. You know, let's be practical. You don't want to chase this 100% you know, facility that has 100% quality and be out of business tomorrow. So I think it is understanding what your elephants in the room are. You know, if your boat is, if the ark, I'm referring to biblical Noah's ark now, if your ark, which is your facility, is sinking in poor quality of care, you know, what can you do within the resources that you have now? You might, if you don't have the money to throw the elephants off, can we start with the hippopotamus? Do you have the money to work on the hippopotamus? And I think also staging it also helps keep you in business. And also making a case. It might also be, so we're saying the health financiers do not care about quality because they don't have enough evidence in country, in state, from facilities about how quality of care works for them. And so we're pushing more facilities, right, in your capstone projects, in HLA, in, you know, with your financial understanding now, to make a case for quality improvement with numbers, with data. Okay, how can we prove that, you know, these quality measures we made towards treating hypertension and diabetes members, their increased compliance, how has it brought around a turnaround effect for that healthcare insurance company? Is it reduced readmissions? Is it, you know, better health outcomes that has reduced complications in the long term, reducing their expenditure and payouts for management of those complications? How can we use quality improvement and put numbers to it so that we have evidence so that this does not continue to be the issue?
Thank you very much, Dr. Kendra, and thank you to everyone who sent in questions. Our time is fast spent.
I would like to
just
ask
a quick...
Dr. Estiko if that answered her question or if she has any follow-up.
Dr. Estiko?
Great, that's okay.
Okay, thank you very much. So just a final thought, and this is because, like I mentioned earlier at the beginning of the session, the HLA is very invested in quality improvement. In fact, it's one of the major pillars for the work that we do, quality improvement and patient-centered care. And as we look into, what I want to highlight is one of the ways in which that we provide trainings or equipping the capacity of healthcare workers and leaders, you know, which is something very important, as Dr. Kendra had mentioned earlier. And I really wanted to just share some insights because she served as a faculty member delivering quality improvement modules. So Dr. Kendra, could you please just share more about the QI modules you've developed and what participants who enroll for programs with the HLA would naturally just stand to gain?
We've had a lot of QI models under the HLA. I mean, I'm super proud to be affiliated with HLA right from the inception. And I am super, super impressed to see like a lot of the alumni from the very first batch on this call. Let me not call names so I don't enter into trouble. But, you know, one thing that I know that I have enjoyed working with HLA is that when you enroll in one of the in any of their programs, it's not about theory. That the incorporation of the capstone project allows you to in real time practice the theory you're learning in the classroom and come back to your peers, you know, and showcase what that theory has resulted to in real life practice in your facilities. And so there have been a lot of programs, either, you know, equipping leaders, facility leaders, state leaders, leaders at the federal level to use quality improvements, methodologies to improve health outcomes, focusing on quality improvement methodologies such as the model for improvements and the Lean Sigma methodology, right? And so those are one of the, and then also the patient-centered care program. Again, I cannot overemphasize, it's not about the patient without the patient. And so this patient-centered programs helps you and gives you knowledge on how to really incorporate the voice of the patient to increase your patient satisfaction, increase your footfall into your facility, and generally just improve improve the quality of care that you deliver. So it's, if you are here and you have not attended any of the HLA programs, it's definitely something that you should sign up for.
Thank you very much. We heard it from the horse's mouth. Thank you, Dr. Kendra. This has been a very insightful and eye-opening learning session, because, especially because there have been some elements that, our guests mentioned that are often easily overlooked in the health space, which, if we pay just some more attention, we can see how important it is for improving patient satisfaction, improving the quality of care we deliver, and even increasing our visibility as healthcare organizations and the work that we're doing in the healthcare space. So thank you very much, Kendra. I, for one, I've been taking copious notes. I hope that everyone else, I've also taken takeaways, right? Regardless of the levels or the spaces in which we work, on how we can work collectively to advance and cohesively, because this is something else that Dr. Kendra mentioned about collaborations and, working, in cohesions as well, how we can advance a strengthened health system. So we hope that everyone leaves this session with a renewed sense of commitment to learning, because remember, we spoke about learning today and exploring new ways that we can advance patient care outcomes, as well as just, the health systems at large to improve care access and delivery. Thank you once again for joining us. We'd like to encourage us to keep the conversations going. If you have further questions, please engage with us on social media, and we'll be happy to take it up from there. Thank you once more. We appreciate you, Dr. Kendra. Have a good evening, everyone. Goodbye.
Good evening, everyone.
Thank you, Dr. Kendra. Bye for now.
Thank you so much, Jaya.